So welcome to everybody who's joining us today. I'm Annie McCluskey. I'm an occupational therapist and a member of the StrokeEd collaboration. This is the second of 5 lectures this month about de-implementation and how to interventions that we may have to change practice and use alternative interventions in place of some of the interventions that may have been used for some time. I acknowledge the traditional custodians of the land on which I live and work, and pay my respects to the First Nations elders and past and present. StrokeEd is an organisation that aims to improve the skills and knowledge and practice of clinicians internationally so that stroke survivors receive prompt optimal evidence-based rehabilitation based on guideline recommendations. Guidelines are written by a large team of health professionals. They're multidisciplinary people who understand EBP and appreciate the value of systematic reviews and trials. And they spend many, many hours, many months and weeks talking and reading about trials and systematic reviews. And they're able to set aside their biases and agree as a team on what the recommendations should be for us to follow. So it's our job to set aside our biases, our personal biases as well. Hand splinting, as you'll hear tonight, is not and has not been recommended as part of routine practice for several years for people after stroke. The small number of randomized controlled trials show no difference when people wear a splint for up to 11 hours a day compared with control groups who don't wear a splint. So you'll hear more about that research and the outcomes of those studies from Laura. I was fortunate to be involved in 2 of those randomized trials back in the early 2000s, led by Natasha Lannon, who at the time was a recent graduate working in North Queensland, Australia. And they form part of the evidence base that Laura's going to be talking about tonight. If the news about splinting research and the outcomes is a surprise to you or doesn't fit with your personal views, your habits, your practices, or what you teach, it will make you feel uncomfortable. And you might be annoyed, you might be angry at me, at Laura, at the guideline authors, which is a pretty normal response when you have to change some of what you're comfortable with and what you've been doing for many years. But that's what we're here to do as a group. We want to make you think and make you think about what you need to change and do differently. So Laura will be summarising the evidence and talking about common barriers to changing your practice. Caitlin and Brittany will tell you what they do when they see people with either no hand movement or with a tight, stiff hand or with flexion contractures. Laura Jolliffe is an occupational therapist and an implementation scientist and an allied health research and knowledge translation lead at Peninsula Health in south of Melbourne in Victoria, Australia. Caitlin Casson is a senior occupational therapist in the same health service where Laura is currently doing her postdoctoral work. Brittany is a senior occupational therapist in a metropolitan Melbourne hospital, Caulfield Hospital and Alfred Health. So I'll hand over now to Laura.
Thank you so much for the introduction, Annie, and to all of you for attending this session tonight. My name is Laura Jolliffe, and it's a privilege to have been asked to present on this topic today and to be joined by both Caitlin and Brittany, who we will hear from a bit later. Now, I would also like to extend my respects for me. I live and work and play on the lands of the Wurundjeri people in Victoria, Australia, and I acknowledge that we're all joining in from various locations, and so extend upon Annie's earlier acknowledgement, I should say. So right out of the gate, I'm going to share the 3 key messages of today's session, and I'll expand on all of this throughout my talk. And these really are that the routine use of hand splinting is not recommended for the prevention and treatment of contracture and spasticity after stroke, that some of the key barriers facing clinicians to de-implement splinting are likely their held beliefs of splinting effectiveness and a connection to their professional role and identity. And that there are some alternative interventions that we can use instead that are goal-based, whether that be on active motor retraining for functional impairment or alternative motor training to elicit motor recovery, such as mental practice, mirror therapy, and electrical stimulation. compensatory strategies to allow for activity participation, or for the provision and evaluation of prefabricated devices like palm protectors to maintain skin integrity and hand hygiene, if that's the primary goal for therapy. Arm and hand impairments are common in people who have had a stroke, and they impact the majority of stroke survivors, and it's been estimated anywhere between 40 to 70% in the published literature. Specific to this session's topic tonight, these impairments may include spasticity and contracture. Spasticity has a varied prevalence and in the published work, and it's been estimated anywhere between 4% up to 45% of people may experience spasticity, and between 28 to 36% for contracture or develop contracture. Just as a quick reminder, contracture is a loss of passive joint range of motion where the muscle's extendability is reduced and a limb or a joint can't reach its full range. Spasticity is an increased stiffness with exaggerated tendon jerks, and it's velocity dependent, so likely caused by a hyperexcitability of a stretch reflex. Carl Scher, who's up here on screen, is a physiotherapist and a member of the StrokeEd team, and has recorded some freely available lectures on both contracture and spasticity. And in these, he talks to much of the research and explores the definitions in far more detail than I have time to cover tonight. So I've put the links up here on screen if you're interested in learning more, and I'd highly recommend you watching those. But ultimately, the presence of contracture on function is certainly an issue and can profoundly affect someone's ability to move. Although spasticity can also cause movement impairments, there is no correlation between the presence of spasticity and the significance of the movement problem. That is, someone may have spasticity but may retain good function. Splinting is one of three ways among casting and positioning to hold a prolonged stretch. And so it's closely related to the stretch, it's closely related to stretch and the stretch research. And tonight I just want to reiterate that I'll be speaking about thermoplastic hand and wrist splints that are used with the aim of preventing or reversing a muscle contraction in the long finger or wrist flexors, or to reduce and manage spasticity, or for the management of pain, or to help a person rest or sleep. There's been very limited research done on other splints that we might call dynamic orthoses, such as the SaboFlex pictured here in image C. And later, Brittany and Caitlin might share with you when they would use casting. And if there is time, we can possibly have more discussion around dynamic devices, such as the SaboFlex. But for today, it's the static splinting evidence, so pictures A and B, that I will be speaking to. Splinting aims to hold a joint in a fixed position with the underlying assumption that this maintains length in the joints, and it then became a commonly held belief among clinicians that prolonged stretch achieved with splinting could prevent or treat contracture to maintain range and thus function. 20 years ago, the evidence for or against splinting wasn't strong. And in 2003, Natasha Lannon and colleagues completed a systematic review and found that most of those studies that explored the effectiveness of splinting were either case series, so 60% of those studies were case series. And of the 4 randomized control trials that were available, none of those showed any splinting effect. But there really was a lack of a no splint control group in any of those studies. And so their review concluded that no firm outcomes on the effectiveness of stretch on contracture could be made. In the time since then, we now have robust randomized control trials that have explored splinting and stretch. So we've now seen this significant shift away from no firm outcomes to what is presented as recommendations in the most current guidelines today, which strongly recommends that the routine use of splints for the management or prevention of contracture and spasticity should not be prescribed. So today I'm going to speak to both the Australian and New Zealand guideline for stroke management. This is a living document and it's updated every 6 months. And I'll also be speaking to the recently published UK and Ireland guidelines published in winter of 2023. So to start with, in the Australian guidelines, in chapter 6 of the guidelines under managing complications, the recommendation statements that are related to splinting are these: that those at risk of developing contracture who are receiving comprehensive active therapy, the routine use of splints or stretch of the arm or leg muscle is not recommended. And in chapter 5, the rehabilitation chapter, the recommendation is that hand and wrist orthoses, inclusive of splints, should not be used as part of routine practice as they have no effect on function, pain, or range of movement. For spasticity, the recommendation related to splints is that the routine use of stretch to reduce spasticity is not recommended, and further expanded in the text below about the benefits and harms of the evidence, we can see that stretch interventions include splinting, serial casting, and prolonged positioning. So the key systematic review that underpins 2 of those 3 recommendation statements is from a Cochrane review by Lisa Harvey and colleagues, and this was completed in 2017. And in this review, the authors pooled studies from a range of neurological conditions. Up on the screen, and tonight I'll be speaking specifically about or focusing on the trials of stroke survivor cohort. Just as a note here about how to interpret these forest plots if they're new to you, and they might be new to a few people, a forest plot is a graphical representation used to show the strength of the evidence across multiple studies. So against each of the studies, you'll see that there's a square and a horizontal line. The size of the square represents the weight of a particular study in the meta-analyses. That is the importance or the influence of that study's results in the overall analysis conclusion. This weight is calculated by considering several factors such as sample size, measurement precision, or methods that reduce bias. So the more rigorous the study, the larger the weight, and therefore the bigger that square might be. The horizontal line extending from the square is known as the confidence interval. A short horizontal line indicates that the study's results are precise, while a longer horizontal line suggests more uncertainty or variability in the results. So if the line is very long, it means the study's findings are less reliable, or that there is a wide range of possible true effects. The diamond at the bottom represents the combined results. So the size of the diamond reflects the confidence interval of the combined estimate. So like with the horizontal lines for the individual studies, a narrower diamond suggests higher precision or confidence, and the overall effect estimate, in the overall effect estimate, while a wider diamond indicates more uncertainty. The vertical line that runs down the center is the point of no effect. So when that diamond crosses this line, or any part of that diamond crosses this line, it means that the combined results of all the studies included in the meta-analyses do not provide clear evidence of benefit or harm. So going back, now we've reviewed how to interpret a forest plot. I want to now talk about the studies that are included in this meta-analyses. So here we can see that there are 2 randomized controlled trials by Natasha Lannon, which evaluated the effect of different splint designs. And then there's 3 other studies by Ada, Gustafsson, and Horsley, who evaluated the effect of prolonged muscle stretch held across varying time periods. So one was on stretch for 30 minutes daily for 4 weeks. Another was 10 hours per position per week for up to 4 weeks. And the other one was 720 hours of stretch for 4 weeks. But ultimately, the results show that the diamond at the bottom, that pooled overall effect of all of the above included studies, crosses the vertical line of no effect, indicating that overall there was no effect found between those who wore a splint and those who, those in a stretch group versus those in a non-stretch group or the control group. At 1 week after the last stretch was applied. In regards to Natasha Lannon's splint trials, participants either wore a resting splint or an extension thermoplastic splint for an average of 11 to 12 hours overnight for 4 weeks. So in her first 2003 trial, she wanted to explore if wearing a splint in this resting position, that first photo with the grey box around it, compared to no splint made a difference. Disappointingly, there was no significant or clinically important differences between the group that wore the splint and the group that didn't wear the splint. Tash Lannon then ran another trial in 2007 and thought, well, maybe if we put people into more extension and we used a different splint, maybe that would prevent muscles from getting that stiffness and that tightness. So one group wore a resting splint, so photo A, another group wore the extension splint, photo B, and the third group had no splint. Despite this time with a person's fingers and wrist in full extension, the difference in outcomes was virtually nil. There was very small differences between the participants who did and who did not wear a splint. Such small differences would or could be considered measurement error and nothing more than that. All groups developed changes in their fingers and wrist muscles over that 4-week time frame, and they all developed increased stiffness or tightness over the 4 weeks, whether they'd been wearing the splint for 12 hours overnight or not. These trials involved several hospitals in Sydney and were both considered robust with strong methods that minimised measurement bias. So going back to our review by systematic review by Lisa Harvey in 2017, another analysis was completed to explore, well, okay, we've looked at the short-term effects. What about the longer-term effects of stretch? So that is there any effect observed from more than 1 week from when the last stretch was applied? And similarly here, we can see that the diamond at the bottom again looks at the pooled data from the above included trials. It crosses that line and this time is a lot wider. So again, this indicates no effect and that it's actually less precise. And we can see that the confidence intervals of the individual studies are much wider too. The systematic review concluded that there was high quality evidence that stretch did not have a clinically important short-term effect on joint mobility in all people with neurological conditions. So this was inclusive of stroke, TBI and CP populations when pooled together, and that the mean difference between all neurological groups was 2 degrees. So if we accept that a 5-degree difference, and some might even argue that a 10-degree difference is considered clinically meaningful, and so what we mean by that is that someone would need to gain 5 to 10 degrees of additional range for a clinical benefit, then we can see that the results for both the short-term and the long-term stretch were not found to be clinically meaningful. Moving on to the evidence that underpins the third recommendation, which comes from Tyson and colleagues in their 2011 systematic review. So I'm going to talk about that in a moment, but I do just want to at this point remind you that while this paper was published in 2011, and I acknowledge that this is more than 10 years ago now, any trials that use good design and minimize bias are still equally valid, regardless of when they were conducted. So the manner and the style of splinting is still the same as those that were made and used by Tashlanen in her trials, and so they certainly hold relevance today. This paper explored upper limb orthoses in stroke survivors against 3 outcomes of function, impairment, so that is wrist extensibility, and on pain. And all analyses found wide confidence intervals, and overall there was no effect on any outcome measure. So on the screen, and I acknowledge that this is hard to read, it's quite narrow text in the paper. This is the forest plot for the effect of the splint plus routine treatment on function compared with routine treatment alone, which you can see there, that diamond at the bottom crosses that line of no effect. And so no overall difference was found between the 2 groups. Similarly, in this analysis on the outcome of wrist extendability between groups who receive splinting and routine treatment versus routine treatment alone, that diamond sits quite squarely on that line of no effect. And again, we can see quite wide confidence intervals there. Before we move on to the UK guidelines, I want to highlight that there have been recently published studies on splinting, like this systematic review in the American Journal of OT, which was published in 2020. But because their method is not as robust as the Cochrane review, and they've included several non-randomized controlled trials, which introduces a lot more bias. For example, unblinded assessors who would have known if a patient had been wearing a splint or not. This can really influence their measurements and therefore the rigor and their rating of the trial or the study. There are several methodological reasons why this systematic review is inferior in design to the earlier Cochrane review that I spoke of, and therefore would be unlikely to influence guideline recommendations. One important limitation is that there was no meta-analyses of the included studies. So unlike the Harvey review, which combines and pulls the data in the forest plots, this study didn't do that. moving on to the UK guidelines, it's important to note here that the 2023 edition is actually a partial update of the 2016 guidance. So all of the 2016 recommendations and statements except for one were carried forward and remained unchanged. Only one recommendation, which I'm going to show you on the next slide, recommendation I, has been added. And this one is about not using eStim to treat someone who has measurable spasticity. The guideline authors had to make a decision about which topics to research and which to leave out until the next update. So they didn't look for or include any new randomized control trials or published systematic reviews between 2016 and 2023. So recommendations G and H are both related to splinting and to our topic today. Recommendation H states that people with stroke should not be routinely offered splinting for the arm and hand. And recommendation G suggests that splinting or casting should only be offered after an individualised assessment. If we look at the sources that underpin these recommendations, you can see that there's a Cochrane review by Catalinic in 2011, which was updated by Lisa Harvey in 2017, and I've already talked through those the study results of that. And again, provides evidence to suggest that we shouldn't be splinting for contraction management. Going back up to recommendations G and H, both of these references look like this. This systematic review is from 17 years ago, which again is not a problem, but it's actually about casting and not splinting. This was another study of Tashlannon's on casting, and I have a feeling this might have been a referencing error. And then they referred to the this guideline that's been endorsed. We know that there's currently a research practice gap between what is delivered in some clinical practice and what we know from the research trials that I've spoken about today. The following published surveys may reflect the views of some of you that are here tonight. And in the UK and in Ireland in 2011 and 2014, respectively, clinicians were surveyed about their splinting practices. And 95% of responders reported that the primary reason for splinting was for the prevention of contracture, and 73% splinted to reverse contracture. 82% of clinicians learnt their splinting practices from joint sessions with colleagues. And the same responders identified a need for evidence-based guidelines for splinting and wearing regimes to help guide their clinical practice. 65% reported fabricating thermoplastic splints themselves, and 45% reported using Scotch cast or fiberglass. It's really difficult to change practice, particularly when you've spent many hours learning how to make splints, or if your workplace, it's commonly accepted as practice. And I'm aware that some university academics still recommend that splints be made and worn routinely in stroke rehab, despite guideline recommendations. And I know that some students have been told that splints will reduce tone or contracture, when this is not really what we see in the evidence to date. This doesn't mean we never make a splint again. It just means that we shouldn't be doing it routinely for people with no wrist or finger extension. Much of my research has a strong focus on upper limb rehabilitation and implementation, and is focused on how therapists feel about the upper limb therapy they deliver and what makes it easy or hard to provide evidence-based practice. One of the key things relevant specifically to splinting is belief about the evidence and a connection to a professional role and identity. I recognise that some therapists may have a really strong attachment to splinting and have anecdotally seen changes in patients, or probably many patients, over a number of years of their splinting practice. But it's likely not the splinting that's the active ingredient. Evidence suggests, in fact, that splinting has no active impact, and what is likely the active and important ingredient is the motor retraining and the other interventions that occupational therapists and physiotherapists are brilliantly skilled at providing. Part of the evidence-based practice is part of practicing in an evidence-based way is accepting and moving on as the evidence does change. In fact, as Annie mentioned at the start of this talk, splinting hasn't been recommended for many years now, and the evidence appears to just be getting stronger about its non-effect. So, thinking positively, what is thought to be effective, and what does the evidence suggest we do instead? So to help elicit motor recovery in finger and wrist muscles, the evidence suggests that we use early, active, task-specific training. We can use mental practice, we can use mirror therapy, and we should be using electrical stimulation. To manage hand hygiene, prefabricated devices may help to reduce skin breakdown and enable hand hygiene. But again, this is based on consensus recommendations, and the effect of this hasn't been evaluated in research studies. So I anticipate that some of that might change over time too. And thirdly, we can be teaching compensatory strategies, for example, helping people to use their arm or hand in other ways within tasks, perhaps for stabilizing or providing adaptive equipment to allow for participation at an activity level. This might be a really nice point to open up the discussion to both Brittany and Caitlin to hear about what they do in their clinical practice. So I will hand over to you, Caitlin. I'm going to pick on you first.
Thank you. So we had a gentleman on our inpatient rehabilitation ward who had spasticity in his elbow, wrist, and finger flexors. Our main focus in his upper limb therapy was on motor training. He had no active movement in his upper limb on admission, and that sort of continued for the first month or two of his rehabilitation. With him, he participated in a program that consisted of electrical stimulation. We used or stimulated the supraspinatus and middle deltoid at the shoulder. Due to the style of our sessions and his postural instability, we couldn't access teres minor in the group setting. We initially also targeted his common wrist extensors with electrodes, also at the proximal third of the dorsal forearm and proximal to the dorsal wrist crease. And then as we went on, we wanted to increase or further target finger extension. So we moved those electrodes closer from the wrist, proximal to the wrist crease, closer to the common origin around the elbow. We also used electrical stimulation around his thumb, around on the thenar eminence and proximal to the dorsal wrist crease. We did trial mirror therapy with this gentleman. However, he found it difficult to maintain attention. He also had a very concrete view of things, both just his general personality, and despite having education, he found mirror therapy very wishy-washy in his words, and he didn't want to participate in it. We did give him mental practice tasks to do outside of therapy, which required him to visualize doing a task like picking up a cup and sort of focusing on key movements we were looking for. This he was more receptive to because he had a sporting background and could liken it to visualizing a movement such as kicking a goal before you do it in a football game, for example. With this program, he was able to activate his wrist and finger extensors. However, his spasticity was impacting his ability to move into extension. So he did receive some botulinum toxin to his wrist flexors and FDS. We did continue with the E-stims and task-specific training. He unfortunately declined to participate in CIMT. But with this focus and also using things like the trigger switch to bring in, make it more task specific, on discharge, he was able to reach and pick up a cup with his affected arm. So we were able to get success without the use of splinting.
When somebody was asking what dose of electrical stimulation and how much per day you were using for that person.
Yeah. So across the muscle groups, he would do approximately 15 to 20 minutes a session per muscle group. And he did this around twice a day, sometimes only once, depending on sort of therapist availability with mental practice in between.
Thanks.
Caitlin.
Hi, everyone. So I'm Brittany. I might talk about my experience as well clinically. Just a bit of background on me. So I also work as an inpatient neurological rehab therapist, but I do also work in the outpatient spasticity clinic at the Metropolitan Hospital that I'm at. And so I have had a lot of exposure to stroke survivors who are many months to years down the track from their stroke, and they do come in often with very tight-fisted hands due to long finger flexion, flexor or wrist flexor spasticity and contracture. And I do prescribe prefabricated options for comfort and positioning. So often the palmar protectors that are on the screen there, or even a rolled up towel often is sufficient. And that's alongside the assessment for spasticity around Botox use. And it is always, when we're prescribing these prefabricated options, it is considering the goals of the patient, the chronicity, the comfort that they require, but also the skin integrity. And that is really the main goal often, is to optimize their skin integrity and to prevent them from developing any pressure injuries in that area. So that is something that I'm very familiar with and that we often do. Certainly there are patients that come into the clinic that have rigid thermoplastic splints. Often we're seeing patients that are working with private therapists in the community, and we always acknowledge that if the splint is working for them, if they're comfortable, they're not developing any pressure injuries, and the person, the stroke survivor themselves, wants to continue with that intervention, then all we do is offer additional options, such as the prefabricated splints if they are becoming more tight, if they're having difficulty getting into the splint, if there's pressure injuries that are causing harm, then we provide education about the options that are available. We talk about the evidence that Laura, similar to what Laura has explained today, and we also provide written handouts with information about where they can source these alternative prefabricated options if they wish. But ultimately, it is their decision at the end of the day. But we always like to have that conversation with them and let them know about the options that are available.
Thanks very much, Brittany. There are quite a few questions coming through, and I think I might start with a couple of them, if that's okay, Laura, before you go on. One that I might answer, because there's two related questions. Somebody's asking, what's the difference between joint and tissue and soft tissue contracture? And that's a very good question, because sometimes we're not really sure. Are we talking about a joint? Are we talking about a muscle? Are we talking about a joint capsule? And often we are talking about a muscle that's getting short, but it may also be that the joint itself is shortening or tightening up. So whatever we are referring to, there's usually a change in the joint range of movement as a result of the muscle or the joint capsule becoming disorganized and shortening. Why that happens, somebody was asking why that happens in the long term. We're not really sure. For some people, it's never a problem, and other people, they do develop changes at the joint and the muscle level. We often see it more in people with traumatic brain injury than we do with stroke. But certainly in people with stroke, it doesn't often happen in the first week or two. So that's one of the first questions that somebody was asking. The second question was about Natasha Lannin's research. And can you see the questions there, Laura?
Yes, I can. Yes.
So wanting to, the Natasha Lannin's articles and studies were involving the acute and subacute population in the inpatient hospitals. And so the question is, what's the relevance of these articles to people longer term post-stroke?
Annie, only because I know you're involved in the studies,
okay.
I kind of want you to answer this one.
Well, we don't actually have much in the way of research involving the chronic population. Although, having said that, the studies that Lisa Harvey included in the catalytic stretching Cochrane review, they had different populations, both early and later after, different neurological conditions, spinal cord injury, traumatic brain injury, and stroke. And with evidence-based practice, when you don't have a study that's directly relevant to your population, you look to the next best evidence. And quite a few of the people in Tash's study were several months down the track, although the majority were early post-stroke. The other question from that same person was, those patients didn't have a contracture at the beginning, would you expect to see any changes in their range of movement if they didn't have any contractures at the beginning? Well, in fact, if you look at the 2008 trial of Tash Lannans, if you look at the table of results in her paper, all the groups started to lose range of movement when it was measured. The stiffness was measured, and the difficulty with moving the joint was measured at the wrist. And all three groups, the control group that had no splint, the group that had the traditional resting splint, and the third group that had the most extended wrist position, they all lost range of movement and really developed a contracture in their wrist and finger muscles at the same rate through the period of 5 weeks that they were measured. So yes, you do see a change in people who initially didn't have any contracture in their muscle or joint, whether they were wearing a splint or not. That takes me on to another study another question about Lisa Harvey's study. That's where she's talking about the splinting studies, where they were remolded during the course of the 12-week period. And was that based on clinicians' judgment, or was it based on some other reasoning? And I know in Natasha Lannan's study, sometimes the splints had to be reviewed or extended if they started to drop. Some of you have made splints from thermoplastic materials will know that sometimes with the weight of the hand, the splint will start to drop down. So if it was no longer being held at the position it was intended to be at, the splint might be remodeled or strengthened at the wrist. So that was what was being mentioned there. And I'll maybe just ask one more question before I get you to go on if there's more you want to say. There's a question about the word routine being used. Many clinicians feel that they're not routinely using splinting, that they're using their clinical judgment. So what does it mean to use splinting non-routinely? So I might give my comment first. We talk about not doing it with everybody who comes into the hospital who doesn't have any wrist or finger movement, which certainly when I graduated and when I was starting to teach at universities, that was what we would typically do. Somebody who couldn't move their wrist and fingers would be put into a splint, and we thought that that would help to prevent contractures. That was part of routine care. So why we say don't do that routinely is because it doesn't seem to have any benefit. But there may be selected people where you might use some type of splint, as Brittany was referring to. I don't know if you'd like to add anything, any of you.
No, nothing really to add, but perhaps I know that sometimes we might serially cast to get muscle length and then motor retrain. So I wondered if Brittany, did you want to comment about when you might use casting? And I know it's a little bit different to splinting, but it's related. So I thought you might be able to say something on that.
Yeah, absolutely, Laura. We do. There is a group of stroke survivors who come through our Spasticity clinic who are appropriate for a trial of serial casting, which is that prolonged low load circumferential stretch over a time limited period. So 4 weeks normally with a serial. The reason it's called serial casting is that it's changed at least every 3 to 5 days to increase the range. And that's really for stroke survivors where we think there may be some underlying motor activity there that they're not able to access due to reduced muscle length. It's normally done in conjunction with Botox injections to help also relax the muscle. And there are some stroke survivors that it is appropriate for, but I do want to reiterate that it is a time-limited intervention. It is also very resource intensive, as you can imagine, having to frequently change the casts over. And it is always followed with the expectation that there'll be an active intensive motor retraining program. So it's to enable that person to engage in a more active rehabilitation program using those principles and interventions that Caitlin and Laura have already discussed.
Great, thank you. Another question that's come up, which is, could you explicitly comment on the benefits of passive or self-assisted range of movement exercises for patients with hypertonicity? So, e.g., keeping the joints moving, preventing complications, increasing circulation. I think patients like stretching. I think it's a nice warm-up activity. I think it's good. I think it's something that is a gentle introduction to active motor retraining. But I also know from the stretch, looking at all the stretch research around the impact of stretching, and not what am I trying to say? Stretching, but is fine, but it's really the active component that's going to be more important. So as an OT, I would spend my time doing active retraining rather than encouraging people sit there and passively range a joint, or spend time in that way. I hope I'm making some sort of sense. It's been a long time of me talking.
I would agree, Laura, that we don't have evidence about the benefits of passive ranging or self ranging. There's some thought that it does keep the joints lubricated, but it does take time away from other interventions, and we have such limited time as therapists to spend with people doing one-to-one training, that it really takes time away from some of the active motor training using mental practice, mirror therapy, electrical stim, and so forth. So it's not recommended in our guidelines, so that's a fair point. If it was something that was going to be recommended as part of routine practice or as even consensus advice, it would probably be in our guidelines.
There's a lot of questions coming in. Let's see. Is Caitlin and Brittany, can you see these questions? Are there any that you want to speak to or address?
The electrical stimulation question there. If electrical stimulation to fingers and wrist isn't so effective, it doesn't give you any extension, would that alter your clinical reasoning to offer a splint or any other interventions like a stretch? I'll give you my opinion first, and then I'll see what the others think. What we're doing when we're offering these interventions and trialing these interventions, there may not be strong evidence for use of them in that particular context. We're trying to elicit some movement in the muscles and trying interventions that we think might be effective. And sometimes we get to the point with people where we haven't got any interventions to offer them. There's no change in their motor performance. And sometimes after a period of a few sessions or a few weeks, we're able to say to people, I've tried all the interventions that I think should elicit movement in your fingers and your wrist, and there isn't any change. So perhaps we need to try again in a few months' time or a year. Come back and see us, or we can organise a referral at that point. It's difficult when that happens, but that's the reality. There are a group of people, probably about 10% of people after stroke, who get no motor recovery in their hand and their arm. And sometimes we don't know who they are in those early stages.
I agree, and I would only add that by offering stretching or splinting, perhaps you might even be giving some sort of, well, not only is it not recommended, but almost a false hope that it would magically do something that other interventions haven't been able to achieve. I'd be really conscious of saying to someone, okay, well, wear a splint, I've kind of got not much else, when we know that that's the evidence shows it's not going to regain movement, and it could lead to issues down the track of potentially pressure injuries or skin issues with hygiene and maintaining hygiene if you were to wear a splint in that way. Yeah.
Brittany, did you want to make a comment?
The only additional comment I would have is that obviously eStim, like you've both mentioned, is for active retraining and recovery. And so if you're moving into having that thought they need something like a splint, perhaps it's actually because you've got concerns about their skin integrity or the ability for them to maintain the hygiene on the palm of their hand. And that's where some of these prefabricated options would be just as appropriate to think about as well. Because often it is maybe they're saying that they are uncomfortable in bed at night, the hand or the arm gets caught behind their back when they're, trying to get comfortable, and it is about just optimizing their comfort and positioning.
Somebody's asking, what about the prefabricated options that were mentioned? Is it just the rolled up towel and the other one on the screen, or do you have any other pictures?
Yeah, I mean, they're the basic starting kind of pack, but there is Palmer protectors that have kind of moisture protectors for in between the fingers as well, for patients who end up, their contractures are so significant they end up crossing, their fingers end up crossing across each other. Crossing across each other is not great, but you start to get that the deviation of the fingers, and certainly that can cause increased pressure injuries. So we would sometimes explore those additional options that have the finger separators. I have had a couple of stroke survivors in clinic who are really uncomfortable at night, and the forearm and the wrist as well as the fingers are causing them a lot of grief. So there are some prefabricated options that have a forearm component and a wrist component that are malleable and soft, and can provide just that little bit of support, and it is really just for comfort and positioning only.
I think the point is that when people are referred to clinics with these really difficult changes in their hand, what you're trying to do is find something that is going to be can be easily repeated. If the person has this problem again, they know where to buy this piece of equipment, or they can get a therapist to prescribe it quite easily, rather than spending 3 or 4 hours making something that may get thrown out with the laundry, which happens a lot in nursing homes or aged care facilities. Something that you can trial with them, or they could take back to the nursing home or back home and trial and see whether it helps with their hand hygiene. But it's on a one-to-one basis that you might be doing that.
Yeah, and it's about increasing accessibility to those options as well for them. That's right.
Yeah. There's somebody asking about a person who is in an aged care facility who can't access regular therapy, has no active movement, and reduced passive range of movement, I presume a contracture in his wrist and fingers. What would you do if he can't access therapy?
Yes, so for a little bit of extra background, sometimes the stroke survivors we're seeing in clinic are living in residential aged care facilities, coming in once every 6 months, not accessing any other therapy or input. And so we do have them using palm protectors, where we give some education back to the facility to say this, they need 2, one that can be, washed, and the other one can be worn and then swapped over, on a regular basis. And we provide a little bit of education about how to manage that, but certainly there are plenty of stroke survivors out there that have got palm protectors at facilities to help maintain their skin integrity, because it is of concern that without having something there to wick away that moisture or to keep their skin protected, that they are at risk of skin breakdown and complications from that.
The good thing too about the palm protectors is they're easy to apply, because I think we need to be mindful of the people that are going to be putting the splints or the prefabricated options onto the person you're working with. They don't have the same level of training or nursing skills you might see on a ward.
Yeah,
that's a really good point, Caitlin.
Now, Laura, did you have any more content that you wanted to talk to before we go on to the other questions?
I'll just check. I think it's just reiterating key messages for today, and I'll leave this references up as we chat. But really, I did expect we'd get a lot of questions, so I think working our way through some of these questions are probably valuable for people listening. So I'll just keep the references up.
I agree. There's another question about, or comment about, Natasha Lannon's 2008 study, where there were 3 groups. And the person's commenting that the loss of range of movement after the splint removal was less in the group that had the wrist extension. And that may be the case, but it was still not clinically important, the difference. And for those of you who aren't familiar with the study, I think it was 5 degrees was considered to be a clinically important difference in the amount of wrist extension at the end of the trial, and there wasn't anything like that amount of difference between the groups at the end of the trial. So for the intervention to be worthwhile for the patients and for the amount of resources involved, 5 degrees change in wrist extension compared with the control group was considered to be clinically important. So it's good to actually be able to talk through different aspects of the studies in some detail, because I think that's helpful. That's what journal clubs are for, looking at the different studies, the methods, the intervention, the methods, and learning to read the results. Now we have a question about the clinical evidence for using electrical stimulation, which is not really the focus of today. So I'm sorry that we won't go into that here. Simone Dorsch did do 2 lectures last year, which are in our library of recordings, one on electrical stimulation for the upper limb and how to use it with examples and videos. And the other lecture she did was on use of electrical stim in the leg. So you might like to follow that up from our library another time. There's also a question about education and handouts for people who use splints when they are given a splint, or perhaps in your case, Brittany, one of the prefabricated ones. What about people who might have cognitive impairment? How might you help them?
Yeah, and that is common as well. We often will engage with either a family member or a carer to give them additional education and to make sure that there is going to be sufficient monitoring in any sense to ensure that the prefab support can be applied. Often it's not the patient, the stroke survivor themselves that can actually apply it. So we do actually rely on carers and family who might be providing support to this person to put it on appropriately.
There are a couple of questions too about, somebody's asking, would you apply the same principles with people who've got a spinal cord injury or a lower motor neuron impairment? We mentioned Lisa Harvey, who was involved in leading the most recent Cochrane review on stretching, which includes splinting as one of the modes of stretching a joint and muscles, as well as casting. And many of the studies in that Cochrane review by Lisa Harvey include people with spinal cord injury. So they pulled that research together and then provided some of the data that Laura showed you. They've subgroups of patients with different, or people with different health conditions separated out. And what the general conclusions are that the different modes of stretching, including casting and splinting, really don't seem to prevent contractures in any of those populations. And Lisa Harvey's done a number of studies. Somebody's mentioned here that one of her studies was in the thumb, not actually in the fingers and wrist. That's correct. She's researched all the different muscles and joints in the hand and the leg. She's used one leg as a comparison of control to the other leg and tried to provide stretch to see if that made a difference to contractures in the calf muscles, and showed that it didn't make any difference. So she really has checked every possible way that stretches could be done, and done very rigorous research in this area. So yes, I think you can apply some of the principles in spinal cord injury, but we do have quite a good body of research on stretching in the population of spinal cord injury. There is a question about splinting versus casting and how they differ with respect to the evidence. So I don't know if any of you would like to comment on that. If not, I can.
I can talk to it clinically in that, casting itself is applied circumferentially and it is worn for 24 hours a day. It doesn't come off. And it provides that low load stretch over that period of time, and then it is removed at that 3 to 5 day mark, and then an increased stretch is applied, and then you recast over that. So I guess in that respect, it's that circumferential element. And if there are periods of time where, in splinting, often the splint comes off or is removed, in this agreement clinically with the cast, it remains on for that period of time. There is no break in that stretch being provided.
I'd be interested, obviously, to hear from Annie, but again, from looking at all this research, we're talking about prolonged, sustained stretch, of which casting does provide. And I do think that perhaps more studies do need to be to look specifically at casting, but I do think that the overall message from all the research to date looks like any prolonged stretch has no impact on preventing contracture. I guess it needs to be more around what the goal is when you come out of the cast, or what you hope to achieve by casting. But Annie, maybe more your thoughts on that.
Yeah, the research to look at is particularly interesting is the trial, one of the trials in particular by Anne Mosley, Mosley, who used elbow casting. So somebody was asking about elbow casting with people with traumatic brain injury. And what she found was the period of casting zero casting was able to make a change in the person's elbow range of motion. But once the cast was taken off, so she wasn't looking at motor training when the cast came off, she was just solely looking at the effect of casting at the elbow. What she found was that once the cast was taken off, the problem recurred. The person started to get contractures again, which is, you know, what you'd probably expect. The other research that's quite interesting was done by Joan Leung, Leung, and Lisa Harvey was involved in that trial as well, where it was with a population of people with traumatic brain injury, and they used a splint and electrical stim on the wrist and finger extensors, mainly on the wrist extensors, while the wrist was in place for a period, I forget how many weeks. And there was some benefit between the control group and the treatment group, but not as big a difference as you might expect. There wasn't significant differences, for example, between the groups. So that's a study to follow up on by Joan Leung, Leung, and Lisa Harvey is one of the authors, looking at splint and electrical stim used together, which is sometimes what will be used when somebody's had botulinum toxin, to see if you can try to get some active contraction in those muscles. The other thing I'll mention with Lisa Harvey's research is she tried to actually induce a contracture in people's thumb and the wrist and finger flexors, and wasn't able to induce a contracture by putting people in that flex position. So it's a very complex and curious area that's had a lot of research, but there's still so much that we don't really know about it.
Those studies too, Carl teases out in that contracture lecture, which is quite good to look at.
Yeah. Somebody was asking whether you'd use a splint after casting. You could, but it probably won't hold the person's wrist and fingers in the place, or the elbow in the place that you want it to be. And really what you're doing is trying to maintain hygiene usually for people. You may be able to get some active motor training happening when the person's coming out of the cast, and that's really what you do with botulinum toxin too. You're trying to get active contraction of the muscles. Let's see if there's any other questions there. What about long-term management of people with, somebody's talking about severely increased tone. I generally find the word tone very unhelpful. It's probably better to talk about stiffness or spasticity. Tone is really an ill-defined and misused term. So if somebody's got tightness or stiffness in their muscles, their wrists and their fingers, I think that's really what Brittany was talking about there. What would you do? Passive ranging would not be a good use of your time. You know, you do it for 5 minutes, 10 minutes, half an hour. What happens on the days you're not there? What happens when they go back home or to their aged care facility? Not much else. So it's not really a good use. It might make you feel good. It may make them feel good. It may not. So I don't know, Brittany, if you'd like to add any more there.
No, exactly. I think that what I've discussed before is those are sort of clinical examples of the most effective approaches. Sometimes those prefabricated options, and making sure that there is a good hand hygiene plan in place, someone that can clean the area and monitor it as well. You know, in really significant cases where we've been concerned, I know there's been a couple of questions there about injections or surgeries. We've experienced both with some of our stroke survivors coming in, and where we have thought we might trial some Botox. This mostly looks like significant contracture, but perhaps that might make it easier for the carer to slightly open the hand to get the palmar protector in. So sometimes we might consider that, or we have referred on to surgeons to do tendon releases and transfers at the very end range of capacity to do much more than that, and when there's really concerns about pain. But it's all very much, you know, really individualized and consulted as part of a larger clinic group. So a multidisciplinary team of a physio and OT, medical, coming together to make that decision, obviously.
Somebody's asking about, which is a good question, the dynamic splints, the Sabo type splints. Would you like to comment on that, Laura, or anybody else?
Yeah, I'm really interested. I think we need a lot more research in the space, but I'm really interested in the the motor retraining aspect of the splint. So allowing someone that slight facilitation of perhaps opening the hand to do the active component more easily. And so I think there is more work that needs to be done. I'd be very interested in being involved in that work, but I guess the evidence is not there yet. One thing that I do, I don't know. One thing we do know is that the flexor, you're more likely to get tight flexion, and so if you've got a SABO that's allowing extension, and then if you're actively flexing, I think it will depend on I think it depends on the motor training program that you use with the SABO, but I think it's a really interesting space. I think definitely more research is needed. Brittany or Caitlin, did you have other thoughts or comments around SABO?
We have access to the SABO Flex as part of our upper limb therapy toolkit, and have used it antidotally with some patients, especially those that have had Botox to help switch off, their long finger flexors perhaps, and they need to relearn how to actually switch on their extensors and strengthen their extensors. And it has, antidotally, I've seen some benefits. Obviously, it needs to be certainly an adjunct to task-specific training, and when certainly not just doing the SABO Flex, it's something that's in our toolkit that we use maybe alongside our other intervention approaches.
Yeah, there is a systematic review that was published, I think, last year or the year before. The lead author is Alexander, who's a therapist from Scotland, from Glasgow in Scotland, part of Peter Langhorne's research group. And the systematic review included I can't remember how many, 4, 5, or 6 small, what we call pilot or feasibility randomized trials. Tash Lannon again did one of them. And they were mostly of the SABO Flex. And what they comment, Alexander's study comments that there's not large enough samples in each of the trials, even when they're pulled together, but the results look promising for improving people's outcomes. And I suspect they're probably doing a trial, which will take them a while to get enough participants, but they're probably doing a trial in Scotland at the moment. That's usually what happens. You do a systematic review while you're doing your trial. So that's Alexander 2022, I think, or 2023, systematic review to follow up. I do know certainly in Sydney, there are a few therapists who run clinics or once a week groups where people can come in and use the SABO Flex kit and be fitted up and do some practice once a week. So it enables them to do some grasp and reach practice with the device on. But it's quite a different kind of splint to the thermoplastic splint that we've been talking about, and which are in most of the trials. Carl Schurz just reminded me that there's a Cochrane review on stretching, which is currently under review at the moment. So there'll be an updated 2024 one by Lisa Harvey's group, which should be published later in 2024 from the Cochrane Library. One of the early questions from somebody here, which maybe Brittany and Caitlin can comment on, is how to make mirror therapy more appealing to people, because many patients try it but easily get bored and end up not being consistent with it. And I think the same applies with mental practice, which I can talk about in a minute.
I think it is something that is really difficult because it does require a lot of concentration and mental effort, and they don't always see a lot of results quite quickly. Often, a lot of what I do is education, and I might do some video feedback. So video them during the session and then show them afterwards so they can kind of see a little bit of what's going on if motivation's quite poor, just to try and keep them interested.
We've done similarly before, Caitlin, as well, with the videoing as motivation.
Yeah. I mean, I would say from using both mental practice and mirror therapy regularly in the workshops that we run through StrokeEd, I think our job as therapists is to be a good coach and to use it in our sessions, help people to apply mental practice mirror therapy in our sessions, make sure that they're attending to it as much as possible. Maybe a short block of, 2 or 3 blocks of repetitions. Maybe they're doing 10 repetitions, another 10 repetitions, or 5 and 5. And then you go back to doing task-specific training or some other intervention that you're using. Then you come back to using the mirror therapy again for a little bit of the session. And I often tell people that in the trials that have been done on mental practice and mirror therapy, people who use these interventions for, on average, 4 to 6 weeks, or about half an hour a day, because there's lots of variation in the dose, they did get better outcomes than people who didn't use the mental practice or the mirror therapy. And you may not see a change in your recovery in your hand in the first couple of sessions, but it's worth persisting. And my job is to help you to do these treatments and to help you as an assistant in the sessions that we have. And you can do some of these back on the ward or when you go home. So I think if we dabble a little bit here and a little bit there, we're kind of feeding into that problem of people not persisting with an intervention. We want to try and get fidelity of interventions as close as we can to the trials that have been published. And if it's 4 to 6 weeks of half an hour a day, which might be scattered through their session with you, then that's what you've got to try and provide to people, whether they're an inpatient or somebody who's seeing you 2 years after their stroke, to try and give them a really good opportunity to try and get their muscles to work again. And somebody was asking about mental practice that I mentioned before. We have a lecture at the end of the month that you'll see on our website by Rachel Stockley, Dan Eves, and Sarah Moore, who ran a very good workshop, I'm told, at the UK Stroke Forum last year for about an hour on how to do mental practice. And so they're going to teach us the workshop and run the workshop for us here online at the end of the month. So you'll see that on our website, and I'd encourage you to come along. And they're talking about the kind of scripts that you might use, how you might start using it, how you might progress the mental practice. So I'm looking forward to that very much. Now we're past the hour and we haven't answered all the questions, but I think we've answered the majority of them. So I want to keep this to a manageable recording and not go on much beyond the hour. So I am going to finish up there and thank everybody for their questions and comments. And thank you very much to Laura and Caitlin and Brittany for the time that you've taken to prepare this content. And I think it's going to be a really good resource for people to listen to after the event.
You've reminded me to change my last slide. Sorry, I got lost in the conversation. All right, thank you so much, Annie.
Thanks,
and
Annie.
hopefully
Thanks,
we'll
everyone.
see everybody at the
Thank
next
you.
lecture next week.
Thank you.
Thanks.